Good afternoon, and welcome to this edition of HDSA ME. This will be our last broadcast of the year, but be sure to join us on January 21st at 2 p.m. when an Ask the Doc session featuring Doctors Veronica Santini and Sharon Shaw from our HDSA Center of Excellence at Stanford University will be held. You can send a question at any time during the presentation. Just click on the chat function in the toolbar, type your question, and hit send. Your questions will be seen only by HDSA, and we'll answer them at the end of the presentation. Today, we're very pleased to welcome Dr. Henry Moore from our HDSA Center of Excellence at the University of Miami Miller School of Medicine, who will explore the impact of COVID-19 in the traditional HD multidisciplinary clinic, as well as the challenges of telemedicine in the care of HD patients and the redefined role of the caregiver during virtual clinics. Dr. Moore is Assistant Professor of Clinical Neurology and member of the Division of Parkinson's Disease and Movement Disorders of the University of Miami. Dr. Moore is certified in neurology by the American Board of Psychiatry and Neurology and has been a member of the faculty of the Department of Neurology of the Miller School of Medicine since 2011. Dr. Moore is a member of the American Academy of Neurology, Movement Disorder Society, and Huntington Study Group. Dr. Moore's clinical and research interests include gait and balance disorders in Parkinson's, deep brain stimulation therapy, ataxia, and Huntington's disease. Dr. Moore has been the co-director of the HDSA Center of Excellence at the University of Miami since 2019. Now it's with great pleasure that I turn the broadcast over to Dr. Moore.
Good afternoon, everyone. So, first of all, saying thank you to the HDSA for the organization of the HDSA ME webinar series, and for the invitation to talk about this important topic about the role of caregiver in these virtual visits. We are living special times, and one of the proofs of that is this webinar doing through a virtual platform that we are now getting used to due to the COVID pandemic. And I'm pretty sure this has caused many struggles on a lot of us, and we have to relearn things. And not everybody was always well equipped to be able to learn this in a quick fashion. So this is the outline of the presentation. We're going to talk briefly about Huntington's disease first, because we have to start talking about our main condition first. And then we're going to jump into the role of the caregiver in Huntington's disease, to then talk about the impact of COVID-19 on our normal clinics, Huntington clinics, and then to talk about the challenges that patients with Huntington may experience, especially on the telemedicine type of visits, and which is the redefined role of the caregiver during those virtual visits. So let's start with the first topic. So just a brief overview. Huntington disease was described by George Huntington, who was an American physician. He died in 1916, but on 1872, he wrote maybe his most important paper on when he was just very young, around the age of 22. And then this paper was published on the Medical and Surgical Reporter on 1872, and you have the piece of the photograph of this manuscript. And then on this manuscript, what he described is observations that he saw multiple generations on the single family on East Hampton on Long Island. They all had some type of abnormal movements. This was hereditary because he saw that it was present on multiple members of the family. And these patients had inappropriate behavior at times that he described may lead to insanity and suicide. So this was his observation. And then he also noticed that it was progressive. And then initially it was called Huntington's chorea, because the abnormal movement that we see that looks like dance is called chorea. Chorea means dance on Greek. But then we noticed that these patients don't have just chorea, they have other type of abnormal movements. So we call it Huntington's disease. So The story is very interesting. So the history started in 1872, of course, with George Huntington writing those papers, which was the description of the disease. But then it took like 100 years to establish something called Venezuela Project. It turns like on Venezuela, around a lake that is called Lake Maracaibo, there is a significant population of patients with Huntington. Perhaps some initial individual that arrived there with Huntington and had a lot of family that make that incidence of Huntington's on these areas extremely high compared with the rest of the world. But that area was interesting because it was exactly an excellent place to study why these individuals have these abnormalities, these neurological conditions. So and they started what we call is the Venezuela Project. And the goal was to discover something. They were thinking a gene because that must be a genetic disorder. So, and that happened in 1983 when they locate the genetic marker, and then the gene was discovered in 1993. And this is the first paper on 1993 published by the Huntington Disease Collaborative Research Group at that time, describing an abnormal gene on chromosome 4 that have something called trinucleotide repeat, meaning that is an expansion. This abnormal gene is a normal gene on chromosome 4, but there is an area of the gene that is expanded, and that causes an accumulation of a protein of the brain that will damage the cells of the brain and produce little by little the dysfunctions. So rapidly we knew that was an autosomal dominant condition, meaning that it was inherited and is transmitted from generation to generation. And then we knew that there was now a gene, it's called the Huntington gene, and this gene was on a piece of the old genes that's called chromosomes. Chromosome number 4, we have 23 pairs of chromosomes. That was on the number 4. That was the abnormality. And then that produced an abnormal repeat of an area of the gene called CAG that will produce an abnormal protein. So all genes become proteins, but this abnormal gene will become an abnormal protein. The abnormal protein will start accumulating on the cells, and the cell doesn't know what to do with it, damage the cell dies, and then depending where the areas of the brain have the more impact of the neuronal death, you will have the symptoms. So we know that it usually starts around the 40s. However, the range is wide, rare on young people, but there are some condition called juvenile Huntington when it usually appears below the age of 20. And usually the patient have three main symptoms called chorea, meaning the movements, dementia, cognitive decline, and some psychiatric features. So the first symptoms of Huntington, that was a series studied, I think, in 1999 by Farut. And then one of the first symptoms, of course, detected is chorea. And you can see here, at least on 28% of the patient reported chorea as the first symptom. But there are multiple others, including trouble with balance, and clumsiness, depression, speech problems, memory issues, lack of motivation, hallucinations, etc., etc. But the important thing to know is this, that most of the patients are unaware when they start having the first symptom. So others may realize that the patient is having the first symptom, but the patient itself that have it is usually unaware. So half of the patients of newly diagnosed Huntington disease that the doctors detect the symptoms, there is a problem in which the patient is not aware that these symptoms really exist. So these are the typical symptoms we mentioned. The motor, the movement is usually headed by chorea, which is this abnormal movement that the patients will develop. But there are other symptoms like dystonia, which are abnormal posture, tics or jerks, stiffness, balance problems, falls, slurred speech, swallowing problems, usually later on, and impaired movement of the eyes. But also the patients have some what we call neurobehavioral problems. The most frequent are disinhibition. Usually they are disinhibited a little bit. Some of them have depression, And depression sometimes may alternate with mania, means the patient fluctuates from a very depressed mood to super happy, very exaggerated happiness, let's say. Some of them may commit suicide, and something that we have to be careful is 5 to 10%, more than the normal population. And some of them are not even sad when they commit suicide. They are just have the impulse to finish with their lives. Euphoria and aggression is kind of typical, usually in some advanced stages of the disease, on which the patient became very irritable and have anger attacks. More infrequent hallucinations, what we call delusions, which are false beliefs, and very rare hypersexuality on these patients. However, there are also some cognitive issues. These patients may experience some what we call executive dysfunction, meaning cognition is not completely correct. They may start having problems planning. They have problems organizing, picking. They go to a store to buy clothes. They have problems picking the right one. They may have problems planning for the future, planning for the week, organizing their tasks from job, for example. They may have also poor flexibility to adapt to the alternative. When something doesn't go the way they want, they have frustration and they get anger easily. And then they may start showing some signs of kind of a mental slowness. They have problems processing the information and going into a solution quickly enough. Memory may be affected later, and some language problems, some verbal fluency. Sometimes they may forget the word that they're going to say, but then the word returns. They may get disoriented, and at the end of the disease, they may have problems taking decisions and problems with judgment to take the right decision for a problem that may occur. So all of these conditions, all of these areas, it starts very mild and progresses, with usually cognition being the one that advances more rapidly at the end of the disease. So the genetics is interesting. These are the chromosomes. So these are pieces of the gene that are being coded. They have 23 pairs. One comes from man, one from that. That's why you have two on each one of the number of chromosomes. But on number 4, there is an alteration. And in this number 4, if we just cut it, let's say a piece of the number 4 here, there is an area that have a repeats of a chemical called nucleotide. And that's normal. Let's say you're supposed to have, let's say, 16 little balls here, and that will make this gene normal. When on Huntington, there is a problem on the gene that make on which the patient was born instead with 16, with maybe 45, 50 of these balls. So you will say, what is the matter with that? Well, the matter is that when this gene became protein, all genes became proteins, the protein will be abnormal, and the protein abnormal will start clumping to into the cell, damaging the cell and killing the neurons, and that will produce the disorder. Again, not all the cells of the brain are damaged at the same time, but usually the problem attacks more the area called striatum, which is the area that deals with the movements. That's why the involuntary movements. So we know that and that's very interesting, that this number of what we call repeats, these are little balls that I showed you on the prior slide, the higher you are born with, the early you may develop the disease. So normally, patients usually have less than 26 is what we call CAG repeats, and that's normal. More than 40, you will develop Huntington's disease. And you see, for example, on this group of patients, a lot of them had 40 of these little repetitions, let's say, and then that will give you usually an age of onset of 40, but there is a range, and there is a range can be as early as even 20 and as late as 60. There are other factors that may lead to this, but the idea is that as the number of repeats increases, the age of onset gets more younger. So the younger people tends to have more CAG repeats. And then what happens once you have the disease is that you are born with the abnormal genes, And then there is a moment on life on which you start having minor symptoms, no movement problems, maybe a little bit problems on cognition, maybe a little bit of depression. We call it prodromal Huntington's, but at some point you start having the abnormal movements. And that's when we call motor diagnosis. And from that moment on, the disease will start getting worse and worse. The motor impairment will arrive, cognitive impairment, the movement, abnormal movements, etc. As that happens, you will progress from an early stage on Huntington's to a more advanced stage. And then who defined the stages was this Schulson and Fan. They define what we call a stage. We'll talk about later. But as this happens in your brain and you get worse on that disease, the brain volume start going down. So you see here, this is the brain volume, the amount of brain you have start shrinking. And then the areas that are important on the brain, especially this area called striatum, which is the area where usually the attack starts, go down. That means that the brain is dying in the areas, and that's why the symptoms are being produced. This is the scale called Schulson and Fan. And then you can see, this is a scale that is on which we assess, we doctors assess on the clinic, on the patient when they come. And we ask the question, 5 questions to the patients. Number 1, questions about how is the capacity of the patient to do his normal work? How is the capacity to manage money? How is the capacity to do normal chores, let's say help on the house, cleaning, etc.? How is the capacity of the patient to do his activity of daily living, basic stuff like cleaning himself, taking a bathroom, going to the toilet, feeding himself, etc.? And then the last question is the patient is able to being taken care of at home, or he needs to be transitioned to a facility because the care has been very difficult. So based on those answers, and if you see the higher the score, the better. So if the patient is able to do regular work, manage the money normally, do all the chores at home, he's independent with ADLs and he lives at home, he will get a score of 13, which is normal. But as the patient starts losing capabilities, then your score will get lower and lower. And that will make the stages. Stage 1 being the stage 11 to 13, which usually is when the patient gets the diagnosis, he's still able to work. When then the patient goes to a stage 2, on which the patient starts maybe struggling with some relationship, maybe the wife doesn't understand a little bit of what's going on. Driving, start getting a little concerned here and planning for the future. The patient is still aware of the condition and he wants to plan what to do when this disease gets worse. Stage 3 is when the patient start transitioning from being independent to being more dependent. And that will be usually a bad stage for our patients. Some of our patients get some swallowing problems, some problems with communicating, and that's when dementia usually comes. Memory is affected, cognition affected. Stage 4 is when the patient is already, when the care of the patient usually not done at home, usually done on the facility. And stage 5, the last stage, when the patient's usually taking care about more advanced care directives, etc., etc. That's the end of the disease. This slide just to illustrate the importance of suicidal on suicidality on these patients being high, 6%, more than the normal population. And usually the suicidal comes when the patient receives either the diagnosis or usually as stage 2 of the disease. So how we manage Huntington's disease? Well, we have to sit down with the patients, explain about the diagnosis, do genetic counseling, educate about the patients. Psychosocial counseling will be very important also for them to handle each stage of the disease, not just the patient, and here it comes, the caregiver. The caregivers who comes with the patient, who is the witness of every single step what's going through the patient. And then it's my job to educate as well as the patient, the caregiver, because at some point the patient may not be very aware of the changes happening to him. And that's when the caregiver will jump in and will help me to help the patient. So information is power, and that's why we're giving you all this theoretical construct at the beginning for you to understand the important role of caregiver to start with knowledge about the disease. Then symptomatic treatment comes in general treatment. So we usually do physical therapy for patients to improve balance, occupational therapy for patients to be able to regain his normal activities. For example, the patient is not able, for example, to eat by himself. The occupational therapist will help him to regain this ability that they are lost. If the patient is not able to turn on bed, or get off the bed, get in the bed, the occupational therapist will tell him how to do it more efficiently, etc. And speech and swallowing therapy, because the speech therapy does both, is also important because at some stage of the disease, the patient may experience choking. So, and we will need to know, we healthcare providers need to know when the patient is experiencing those aspects so the patient can be properly referred. Is the patient going to call me and tell me, Dr. Moore, I'm having problems choking? No. Most likely is the caregiver or the wife, the husband, the spouse is going to notice that. So we need to all be paying attention to this so the information can come to me for me to take decision what to do next. So in terms of treatment, the involuntary movement, which is the most bothersome movement called chorea, is due to an overactivity of some chemical on the brain called dopamine. So medications that block dopamine are welcome to reduce the involuntary movement, because sometimes this involuntary movement doesn't let the patient do his activities. And then the old dopamine blockers are not good because they have a lot of side effects. So we have two new ones. One was called Senazine on 2008 and one Austedo on 2017. And these are being FDA approved. And we need to understand that these are the standard of care for Huntington's for the chorea part. But they won't help the behavioral problems. They won't help the cognitive aspects. So going back to treatment on behavior, how we do that, if the patient experiences depression, irritability, or obsessive compulsive behavior, sometimes they get stuck on the same idea on the head and they cannot go away from that. And then they ask you the same question over and over. And that's because they are not understanding. It's not like they're not understanding the answer. Sometimes it's that the patient really have the idea coming back to his brain, and it's like an OCD type behavior. Well, there are medications for that. And then you just don't read the slide yet. There are medications that can help on that stage, but I need to know that. Caregiver, patient will have to let me know. If there is anxiety, there are medications for that. If the patient has hallucinations or he has false beliefs, there are medications for that. And same way for cognition, if the patient, once the patients are having a cognitive decline, it's good for the doctor to be aware so they can do a formal memory evaluation to have at least a standard, a baseline on the patient. And unfortunately, there are no good medications for cognition of our patient with Huntington. Some have been studied with no good results. Sometimes adaptations at work or home and cognitive behavioral strategies that usually are done by neuropsychologists are good. Sometimes we recommend the patient to engage on mental activity, reading, puzzles, Sudoku. There are even websites that can give you, you just pay a little fee per year and you can get access and do some mental exercise. And then there are places that have something called cognitive rehabilitation, which is a more structured way to help the patients to regain cognitive abilities that are being lost. So, but this is all what we do. So all of these are every single symptom of Huntington, and all of these are the strategies. Of course, all of this is in our brains when we see a patient, but I need from the caregiver to tell me what is going on and the patient to tell me. But if the patient doesn't, the caregiver then for me to act on that and improve the patient. But the therapies don't stop there. And then now on the pipeline, there are multiple medications that are coming, and you can see some of them are approved. So the ones that I talk about, but multiple others coming. And some of these others are medications that potentially may slow down Huntington. They are medications that work on the Huntington gene. And then they call gene therapy, and that potentially may slow down the condition. Again, it's not proven yet. The studies are ongoing, so we'll have to wait about that. But at least it gives us hope that the field is moving in the right direction. So what is the role of the caregiver in Huntington's disease? So living with Huntington may mean multiple things. May mean that you have the symptoms and you are symptomatic individual in the house. May mean that maybe you don't have the symptoms, but you're seeing that your brother has symptoms. You know that your father had symptoms and you're wondering, am I going to develop the same condition? So at that moment, you are at risk for Huntington disease. You are in the family. So the only way to clarify you're going to develop the disease or not is do a genetic test at this point. And then the other, being at risk, you may be able to help the patient that is symptomatic. So at that point, you may become a caregiver of your parents or your father, for example, or your brother, etc. But the other way is being the caregiver. Maybe you are not symptomatic. Maybe you are not even at risk because you are not part of the family, but maybe you are a loved one. Maybe you are a friend. Maybe you are a close one. Maybe you are the spouse. In that moment, you became a caregiver. Somebody that's going to step into the patient's shoes and it's going to be the voice for the patient towards the physician. Why? Because somebody has to be the right voice, providing all the information for the physician to improve the patient and to be aware of what's going on. So caring for the caregiver is important. Caregiving is an act of courage, love, sacrifice. As a caregiver, you have chosen to put the well-being of a loved one with Huntington's on your feet. There is no higher calling of caring for another. But being a caregiver has big questions. And then number one is, why do I face it? Why I'm going to be the caregiver here on this family? How will I face this? What can I do? Why did things change? And then why is the purpose of this suffering if you see this as a suffering, and it shouldn't be? So there are the caregiving, when that somebody becomes a caregiver, when somebody is on the family and becomes a caregiver of your, for example, your father, then it changes your life. It's like you start a personal journey, like this walker here. So, and however, you will have to get you have to pack some helps, something that helps you on your journey. Like this guy is packing before starting the journey, he packs food, and then he packs, I don't know, a sleeping bag, etc., etc. So you need to pack some stuff to be able to carry your journey with less effort and with less sacrifice on your part, and taking care of yourself also. So that's why the caregiver start getting into relationships with other people. And then other people could be other people with Huntington's disease. Maybe you can find those on support groups. Maybe your religion, it could be your support, your philosophy, the appreciation for nature, feeling of connection. So everybody finds a different way of saying, okay, that's the reason why I'm a caregiver. And I'm gonna surround myself for spiritual and also material help in order to continue my journey and not to struggle. So the caregiving is an uneven process. Don't think it's gonna be a nice and steady process. It has up and downs. And then there are moments in which you are saying, why am the caregiver? Why to me? And then you would like to quit, but you should continue, because as you overcome the up, you may be on the down area, and then you may be able to continue for some time. So it's worth the effort. That's the only thing I can say. Is worth the effort completely, and the patients need it. So caring for the caregiver is important. You are going to work with big changes. It's a big change, a big shift on your life. Sometimes the patient you now relies on you, So caregivers sometimes may feel tremendous guilt that they are fine, and then their loved ones, they have a struggle with this condition. Sometimes in trying to find the best solutions for the day-to-day problem that a patient with Huntington's has, they start getting stuck. They don't know how to handle it. They may get depressed too, the caregivers, because they don't know, they don't find the solution. They get demoralized. However, you need to know that you are not alone. You have a lot of resources. And then Then understanding and managing uncomfortable emotions. We are humans, and sometimes if somebody is irritable, we tend to respond with the same irritability, and that shouldn't happen, but it's human. So we will pass through periods of sadness, grief, sometimes guilty, loneliness, and that's how the support groups will help us to understand how others live with this disease, others that maybe pass through the stages on which we are, and then can teach us something about dealing with patients with Huntington's disease on the best way and with a lot of love. So stress is part of the caregiver situation, and then managing stress is challenging sometimes. Sometimes there are some clues. It's easy to talk different, I know, to be myself on your shoes, but I will say prioritize. If you have too many things going on with the patient, prioritize which is most important. Make lists, establish a daily and weekly routine for the patient may help a lot. The other thing that is important is identify things that trigger outbursts on the patient with Huntington. You know that they are irritable now, so try to identify which things make them irritable and try to avoid those. So ask and accept help for friends. Sometimes we are reluctant to accept help. We don't want anybody else in our family to know that the family has Huntington disease and this and that. We need help, so we need to accept the proper friend or the proper family or the community. Some people in the community may help us. So we need to learn about the caregiving resources. They exist, but we don't know. So that's why we get overwhelmed. Maybe we read those in advance, we will be able to cope with ourselves. So there is, for example, adult daycare. So when we are a little bit fatigued of taking care of the patient, we can have a break. We can have some vacations. We can take the patient to this adult daycare, and we can request respite centers to help us. And then we be ready to say no. Sometimes there is too much on your plate. So sometimes you may need to say no when they want to put more things in your plate or to give you unnecessary additional tasks to do or responsibilities. Consider taking a break from your job. There are certain jobs that allow you to take certain weeks to be able to take for your loved one. And then control your reactions, of course. Try not to hurt when the patient you are caring is difficult. So remember that the patient is not speaking by itself. It's the brain that is abnormal and is producing these responses. So caregiver is not alone, and thanks God we live on this modern era, 21st century, on which we have a lot of online resources, internet, we have Facebook, and we can connect with friends, we have Instagram, we have Twitter, we have a lot of social media, videos, YouTube, etc. However, we need to pick and choose because some of the information that is there may not be accurate. And that's how the HDSA plays an important role here. The Huntington Disease Society of America has been one of the leading voices on Huntington's around the globe. And then it provides real information, and information that you can trust on their website, which is hdsa.org. So HDSA has a lot of resources for the caregiver. It has, for example, information for youth people with Huntington's, caregiving services and resources. They also have telehealth services. They have the support groups on which you can go attend and learn or share your experiences. There are a group of social workers that belong to the Center of Excellence of Huntington disease on the community that they may be of help for you, that may know things that a caregiver doesn't know. And they have a huge resource library with a lot of publications written by professionals on the topic that may be able to help you. Support groups are very important, and the support group, usually what you do is you connect with others who already understand your journey. You build relationship with them. You hear experiences of patients and caregivers about what's going on with the Huntington, what problem they have, how they solve the problem. Maybe that's a good idea. You can take note for yourself or for your loved one. And then you need to understand that seeking support is not a sign of weakness, because seeking support is seeking knowledge, and knowledge is power. And that just put that on your mind. So the social worker is key, and this is the checklist for my social worker. That's all what they do. They do a lot of things, starting with getting involved on what insurance the patient has, if the patient has family support or not, if there is some suspected patient abuse that sometimes happen, unfortunately. So they also address the specific needs that the patients have, medical equipment that the patient may need. If the patient needs a medication but the insurance doesn't pay for it, they can get the patient into patient assistance programs. So they help the patients and the families with advanced directives, for example, living wills, power of attorney, etc. So if the patient with Huntington is in a situation in which we don't know if he should be driving or not because the disease is progressing, they assist with driving evaluations. The social workers may also help you, providing you the tools to obtain a parking permit on which you can park your car closer, let's say, to the entrance of, for example, supermarket, so the patient doesn't have to walk so long. So if the patient is more advanced, he may need transportation needs, and then the social worker is the one that has those resources. And then they may also help you applying for disability. They also may help you with long-term care if you have long-term care disability insurance, or the long-term care facilities. When the patient with Huntington goes to an advanced stage, care may not be provided at home anymore, so they will give you a list of facilities that may be able to provide a service and then to treat very well your patient, your loved one. They may also help you with educational material and our community outreach activities. So this is one of the guidelines that the HDSA have. It's on the Huntington Disease Society of America website. It's called A Caregiver Guide for Huntington Disease Family. I read it completely. I love it. And it's good for caregivers. Don't pretend to read on one day. It's gonna take you a few days to do it, but each chapter is very interesting and will give you the power, the knowledge that you will need to treat better your loved ones, and all that, a lot of clues over there and keys how to succeed on your role of caregiving. So unfortunately, COVID-19 has been impacting our clinics. Normally, we have our Huntington patient. The patient is surrounded by the caregiver, usually the family. And around that patient, there are a lot of professionals that get involved. And that's the reason why our clinics for patients with Huntington are multidisciplinary, involve multiple professionals, each of them treating a different aspect of the whole patient. Of course, the family has to be there providing information. That's the role of the caregiver. So who is there is usually a neurologist, sometimes a psychiatrist, therapist, a genetic counselor, a social worker. We even have HD nurses, etc., etc. And when need comes, they will put you in contact with long-term care facilities, for example, nursing homes, etc. So COVID, and this is a picture of COVID-19, an unfortunate virus that we have to deal with through this year. So has changed the way how we practice medicine, an impact on patients, providers, meaning doctors, and caregivers. For example, patients have to all of a sudden learn what is telemedicine. They have to deal with technology, that maybe they have an iPad just to maybe check the email and then get into a social network. So now they have to be able to go into a portal of a care center or a clinic, and then log in and then find the appointment and then see the doctor on the computer. And then COVID also brought a lot of cancellation, because when the virus arrived, we had to close our clinics because we were on lockdown situation. And patients start being concerned about what happened if my loved one developed a disease that needs to be treated in the hospital. So if the virus is there, he may get infected, he may have higher chances to get infection. And in addition to that, a lot of our patients with Huntington had already physical therapy in place, occupational therapy, speech therapy, And now you deal with a situation on which you may not be able to do it, that the clinics were canceled, etc., etc. Stress increased, the symptoms of the patients worsen. But the same thing happened with caregivers. They need assistance during virtual visits for our patients. So they have the role of the caregiver changed a little bit. Now they have to be the technological assistant for the patient. Otherwise, the patient won't be able to deal with the technology to be able to get into the visit with the doctor. They have to, the caregiver were concerned about the quality of the visit. If the visits on the computer may not be the same. And then, of course, if the patients are not able to leave home because concern of the virus, the patient will spend more time at home, and that will be an increased burden on caregivers. For providers, clinically, we have to start dealing with an examination which is not live. And then when it's live, it's a problem. The light of the house, the patient is not appropriate. There is noise over there. The connection is not appropriate. We cannot do certain examination. I cannot do examination of balance if you are on your house and I am here on my house. So, and also research was affected. Is a lot of research in Huntington was also canceled or placed on standby. And thanks God, a lot of that has been restored, but with some changes on the research protocols. So there are pros and cons of this telemedicine, and telemedicine is come, and this was kind of COVID-19 help us to rapidly realize that telemedicine is important and we should use it more. However, it has pros and cons. Pros that you can be able to take care of yourself at home with minimal waiting time, is secure. There are some platforms that are very secure and safe. However, a lack of this relationship, the patient with the doctor, right? So it requires knowledge of technology in our patients. It requires the patient to have a computer, the patient to have internet, webcam, a mobile phone. The quality of the images may not be the best, so the doctor may be more reluctant to call it Korea, maybe he's not sure. And then the other con is that the technological part, sometimes in order to get into the visit, you need to disable pop-ups on the computer, and only the young people know what a pop-up is. Sometimes they tell you, the system says you have to install this software, and then even my parents, that they don't, sometimes they struggle with that. Imagine a patient with Huntington disease that already has some problems on cognition. So this telemedicine visit involves multiple things. Number one, patient access. So if you want to do telemedicine, is the patient able to get into the system properly with an appropriate platform, internet connection, etc. Number two, it has to simulate the hospital or clinic environment. So I cannot be in a place in which there is a lot of noise, a lot of background people playing behind the patient that I'm trying to examine. So, and the clinical part is important. So we are not trained to examine patients on the computer. We learn how to do it over this pandemic, but we are not trained for that. So we need to create guidelines of how to train, how to examine patients virtually. And then, believe it or not, a Huntington exam has a very important part, which is the balance that we cannot assess. And then there are maybe also other modifications that may have to be done to the rest of the exam. So to properly tell you with certainty that your loved one is changing on stage, or that they need a change of medication, etc. So in order to that, the Huntington study group, which is very involved on Huntington studies, so is initially proposed this study that was run by Dr. Dorsey and Bigland, very well known on the Huntington's community. They did first a pilot study to see if this is feasible, if it's feasible to do visits with Huntington disease patients online. And then the answer is that yes, it's feasible, it's possible, and it's reliable. But there is some issue that you cannot examine, which is rigidity and balance. And that's important, that not to be able to determine the patient is at risk of falling is a major negative for the exam. because that would normally trigger for me to say, okay, we need to go to physical therapy, we need to do this exercise, we need to do these precautions, etc. Now I may not have this ability. So the examinations have to improve for the virtual platform. Now the Huntington Study Group is trying to develop a program on which we will improve our normal scale, the scale that we use called UHDRS. This scale is used normally to assess Huntington symptoms in person. Now we're going to improve this scale to be able to be very reliable and accurate when we examine patients virtually. This project will most likely, it was announced this year, a few months ago, and then will start most likely next year. So, and telemedicine has been with us at the University of Miami, where I practice, but I assume on most of your facilities, all of you patients are being treated. Most of them already are familiar with telemedicine, on which you can log in, and then using a platform, you can see your doctor, right? Either on your iPad or on your computer. Of course, an iPhone or a small cell phone, a smartphone won't be really good because you will be moving with your movements, and then the doctor will be able to tell how are your movements from head to toe. There are other platforms, and you have FaceTime and Doximity, which is a platform that doctors use. And there is one also called Doxy.me. Some of them better than others. But the point I want to make is now we learn that we can do these multidisciplinary visits on Huntington's on the virtual platform. So it's these clinics on which you had a neurologist, then a genetic counselor, then a social worker, then maybe a psychiatrist talking to you, a therapist on the same clinic, and that's called multidisciplinary clinic. And that's usually typically seen on Huntington Disease Center of Excellence. These clinics that may not be able to be done properly now on the COVID days can be done virtually, because the virtual platform allow multiple specialists to be on a different window, and then to one be after another one taking care of the same patient. So if you have the capability of doing telemedicine, we can, and a lot of centers, I'm sure, will be able to transition to a multidisciplinary clinic online. So what is the redefined role of this caregiver? So now with the telemedicine, now with the COVID that forced telemedicine, and now with telemedicine going on, then there are some other elements that are being introduced before the visits. So before the visit, the caregiver role changed a little bit. So of course, he needs to take care of the update of clinical issues since the last follow-up. Very important for the caregiver. They need to be able to give the doctors, the providers, a summary of what are the issues that are struggling with the patients in the most. So which are the most important issues? Is the patient mainly irritable, and that's the main reason of the visit? Is the patient involuntary movements out of control? Is the patient falling? We need to know that from caregivers, and hopefully now with this learning that you got through this presentation, you are able to now take note of that. The second thing the caregiver have to do is an updated medication list. So very important to know exactly what the patient's taking, not just for Huntington's, for other conditions, because some medications for other conditions may also be bad for Huntington's disease patients. So we need to know that. We don't rely in the patient's memory to do that, because I don't rely even on mine for certain things. So please, bringing a list will help. And if the caregiver can kind of make sure that the list is completely correct and accurate to the date, that will be important. Then the caregiver role is scheduling the telemedicine visit. Patients with Huntington are going to have a very hard time to do telemedicine by themselves. If there is no caregiver, it's going to be almost impossible to have a good telemedicine visit. Remember, the doctors only have a frame, a 30-minute frame to see follow-ups, maybe an hour to see a new patient. That's it. So you're going to spend the 30 minutes from the 30 minutes visit, 20 minutes dealing with a computer that you cannot log in, that pop up, that I can see you, but I cannot hear you, or that I don't see the image, I only see your face, I don't see the rest of your body. So if we're gonna deal with that 20 minutes, then your visit really is 10. And 10 minutes is not enough to see a Huntington patient. So we really need the scheduling of telemedicine visits is gonna be very important, and caregivers have to step up there and address that and help the patients. So the second is during the visit. During the visit, while the visit's going on, so the caregiver will have to assist with the connection with the platform navigation. So sometimes the patient has problems picking the right move, pressing the right button, etc. So you are there to assist. If the patient with Huntington is young, it's possible that he may not need help, especially at the beginning of the disease, but may need on more advanced stages. Appropriate home environment, very important. I need the house, the home of the patient, if we're doing virtual visit, to mimic what is going on in my clinic. No noise, or to keep the noise to a minimum, on maybe a room on which we have some peace and we can just discuss our issue without having background noise. And then the next thing during the visit is I would like a summarize a list of recommendations to be written by the caregiver. So once I finish my visit, I will give the caregiver and the patient the recommendations. Okay, I'm gonna say, you have 3 main problems. For problem number 1, we're doing this. For problem number 2, we're doing this. I want somebody that receives that information, write down, and make sure that it's accomplished before the next visit. It's not the first time. I have multiple patients that come to my visits with nothing being done. It's 5 months past, 4 months past, and nothing was done what I recommended. And then I know doctors are busy, but if you call me, I'm there to answer the phone call. May take a day, but I will do it. So please make sure everything discussed on the visit is done, because it's for the patient health. And understand that if we do this properly, it's less burden for the caregiver. So that's the other issue. So and after the visit, we need assistance of the caregiver with the changes that we recommend. If we recommend medication changes, the caregiver has to be there assisting that. See, if we order some tests, a memory test, some physical therapy, caregiver has to be behind that, calling the facility, making sure the appointment is confirmed, going there, taking the patient. The patient may not be able to move by himself. He may not be able to drive. He may need help. So then it's important after the visit to schedule the follow-up. Some of my patients leave the visit and never come back, and then we have to call them back and say, okay, you didn't make another appointment. So they schedule the next visit, which could be in person sometimes, or telemedicine. Sometimes I recommend, when the patient already have a telemedicine visit, I say, you know what, the next one, let's make it in person, so I can make sure the balance issues are addressed properly, etc. So after the visit, the caregiver have to reach the healthcare professional for assistance. It's your duty. And I am there, and all healthcare professionals are ready to answer and to help you, but you need to reach to us. I know it may be difficult sometimes, maybe by phone, maybe by email, maybe by messages on the portal, but you need to reach me. You have a question. Don't get overwhelmed without no reason. Maybe there is an easy solution for your problem. There are 2 other guys that will be able to help you, the social worker and the genetic counselor, maybe for assistance for you. So when I cannot help you, and I know it's a problem that is better assisted by social worker, I immediately send you there. So you continue receiving help from somebody that can give you more information than I can. And then finally, get involved in the support groups. Get involved in your community, because that's the way you learn more about this condition, and then easy ways, easy solutions for common problems that you will experience day to day. In conclusions, so hopefully this lecture was able to give you some important teaching points. Number 1, in order to be a good caregiver, you need to get familiar with the disease. You need to get familiar with Huntington's. And doing that, you will be able to better understand and assist our Huntington disease patients. Number 2 is that caregiving is an act of courage, dedication, love, sacrifice. It shouldn't be an obligation. You should see that as an opportunity to help others. It's a long road with ups and downs, but it's worth the effort. And COVID-19 has changed the way we practice medicine. I don't know if everything is bad. I know there was a lot of patients dying from this, but we always learn from the disaster. And then maybe that was the time to learn that telemedicine may be helpful. And maybe that telemedicine should be incorporated into regular care on certain patients that cannot come to our visits because they have problems moving, because they live so far, or maybe to be able to see the providers more often. Maybe the provider doesn't have a slot of 30 minutes to see you in person, but maybe can talk to you on 10 minutes and see you through the computer and examine you. So COVID-19 has propelled the development of telemedicine. And of course, that forced us to transform what we had in person in virtual. So multidisciplinary clinics of Huntington, which are usually done by the Huntington Disease Center of Excellence. And they really encourage you have Huntington disease, to be connected with one of those, the closest to your community, has become, most of them, virtual, and they are feasible. These clinics are feasible and reliable. Of course, they need some adjustments. The scales that we use have to be adjusted to be really more reliable, and this is a work in progress that I think we will be doing. And then finally, you need to understand that the role of the caregiver in virtual visits has definitely changed, but it's still feasible. And information is power, and you need to get information, get it there, try to help your patients, try to help the people you love, and remember that this is feasible and rewarding. You may need help on the way, and don't hesitate to look and reach for us, the Huntington Disease Center of Excellence, or you can reach the Huntington Disease Society of America website that is flooded by information. You can join a Huntington's disease support group or your local social worker. So with that being said, I'm going to stop here, and I'm going to open for questions that you may have.
Thank you, Dr. Moore. That was a terrific presentation. We are just at 3 o'clock. We do have time for maybe one or two questions. The first one came in from someone whose brother seems to be in the late stage, as per your chart, and is in a nursing home, but he has an excellent memory. You have to wait for his response, but we're all surprised by his memory. How is that happening? He leans more towards rigidity than chorea, and is 64, older than anyone affected in our family.
So the first one is a patient with memory problems on the nursing home, right? Or memory okay on nursing home. Is that correct, Deborah?
He has an excellent memory, but you have to wait for his response. And they're surprised at how good his memory is.
Exactly. So that's what I was talking on the lecture, right? So sometimes memory is not the first aspect of cognition to be affected. Patients with Huntington's have other areas of the cognition that are affected first. And usually is, for example, the planning, organization, we call executive function, calculation capacities, or ability to take decisions quickly. So this is the problem. The centers of memory on Huntington's patients is preserved until the later stages of the disease. So you may have somebody with advanced Huntington's with a lot of chorea or slowness, a lot of problems with balance, that is already in nursing home, that still has a preservation of memory, and is completely normal. Remember, the opposite will be, the example in which memory will be affected first will be Alzheimer's disease, and this is completely different than Alzheimer's disease.
Okay. We have another question, which will end our time today. And this is actually asking for some strategies. My sister lives with her caregivers full-time who are isolating even though I am in town. The HD clinic wants to make an appointment with us together, but her caregivers need to be isolated from me. So how can we get everybody together?
Yeah, that will be that will be a good moment for the telemedicine. I don't know if that clinic have some telemedicine virtual clinics, no? When isolation have to occur, the way to get connected is through technology. And that's why all the Huntington Study Group and the HDSA are working on improving the quality of our virtual visits through training to physicians and improving the skills we use to better assess those. So I think it's glad to know that the sisters have a caregiver that is there, but I think the use of technology, my recommendation will be use technology. Remember that the visit doesn't start the moment of the patient is on the clinic, starts before and continues after the patient leaves the Huntington clinic. So you are able, the caregiver is able to contact the physician before, maybe put him at current about all the situations that are happening, even before the clinic. You can send email, you can call the caregiver. And then during the visit, if there is no telemedicine, then there are things that can be done after that to make sure that every single recommendation that was given on that visit is accomplished.
Thank you, Dr. Moore. Those are our questions for today. We would like to remind everyone that we will be featuring an Ask the Doc session on January 21st at 2 p.m. As we relaunch the series for 2021. I want to thank Dr. Henry Moore from the HDSA Center of Excellence at the University of Miami for this really terrific presentation today. And I want to wish everyone who has joined us today a happy holiday season and to stay safe and practice your social distancing. Take care and have a happy new year.